Welcome back. Professor Ishaku Akiela joins us now. He's a professor of infectious diseases epidemiology. And we're talking about the outbreak of the Hantavirus, which you understand is a family of life-threatening rodent-borne viruses that can cause severe respiratory or kidney illnesses in humans. I think the first question that Nigerians will want to know is, how is this different from Lassa fever? Because that's one we know that rats and rodents carry here in Nigeria.
Absolutely. Good morning, Marupe. Good morning, Nigerians. So it differs from Lassa fever because virologically they are of different viral family. One is caused by hemorrhagic fever, which is the Lassa fever. This one is from the family of Hantaviridae. They also differ in terms of their clinical presentation, but also in terms of the rodent diversity. They differ. So it's basically two different types of rats. That is not commonly seen in this part of the world for the Hantavirus.
So we don't have those rats that carry that?
No any documented species of the rice mouse that has been established in West African coast. But in South America, part of Europe, those rats are quite available in relative abundance.
That's what they call
yes.
rice mouse.
Yes, they call them rice white mouse. So they differ in terms of their vector rodent differences. So basically, and also in terms of their clinical presentations, they differ. This one causes a very, very severe pulmonary syndrome, the Hantavirus. It's more of a respiratory disease. It looks similar like COVID, but in terms of clinical presentation, while that of Lassa fever. And this one has a very longer incubation period of 1 to 8 weeks, while Lassa fever is just 1 to 7 days. So they differ in terms of their incubation period, differ in terms of their clinical presentation, differ in terms of their rodent specificity, differ in terms of clinical presentations.
Well, we know that this broke aboard a cruise ship. And some people say that's one of the ways that diseases move from areas where they can be prominent or where they are known to locally occur to areas where they have no, where they can never occur. We also know that this ship traveled all the way to Cape Verde.
Yep.
That's something we know. And
Yep.
Cape Verde is around the West African
Yep.
coast, even
Yep.
though you've said that
Yep.
with the rat that carries it, the vector that carries it,
Yep.
we don't have it in abundance here,
Yep.
and there's been no known documentation of it. But do you think that West Africa, speaking broadly, could be at risk as a result of this sort of movement?
Absolutely. So I did my PhD in the Netherlands, and I was able to be part of a cruise ship in 2015. And we toured about 20 countries. So I understand the dynamics of the transmission. So we are at risk. This is because the strain that is responsible for human-to-human transmission is called the Aedes strain. And because we don't have the rodents in relative abundance in Africa, does not mean that we are not at risk, because we have the rodent-human transmission and human-to-human transmission. Now that the ship voyage docked in West Africa, it shows that actually we're at risk. It left part of Argentina down and traveled down to West African coast. Of course, in 2018 and 2019, that island in Argentina, also there was an outbreak of Hantavirus. So it shows that we need to actually mount active surveillance within the West African coast. At the moment, this morning, I've consulted senior colleagues, senior friends in African CDC. We don't have a dashboard for early sign warnings. It raises a lot of continental concern about public health, global health security threats. Giving out travel advisory is quite key. Even in country, we don't have a dashboard that speaks to early sign warnings, public health emergencies. For example, you want to move from Abuja now to Nasarawa State. Which disease is more prone in Nasarawa State that you need, from the state where I come from, that you need to be careful about? So we need to see to how we can raise a national initiative of having a public health disease dashboard, a live public health disease dashboard that is AI-enabled. I overheard you discussing AI with, you know, like that. So, of course, you could imagine that people are in the cruise ship and then they were able to detect the virus, did analysis, sequence the virus. It shows that a lot in terms of public health warning, signal warning. So I agree with you that the West African coast, we need to be alert. We need to mount our sea borders, air borders, you know, all the borders, land borders. We need to, you know, have an active surveillance sat, you know, in terms of activate all what it takes in terms of framework for us to nip this on the board. Not only Hunter, we have a lot of diseases that are transborder. And you know, with globalization and international travels, those are drivers, catalysts for emerging and re-emerging diseases.
I don't know that we've seen a statement from our NCDC yet. Perhaps it's not yet something that we consider something for us to be aware of. Let me put it, to be aware of. That, I think that's the word to use there. Because do you think that we're being too laid back on this? Or do you think that there has been maybe a discussion, an assessment of it, and maybe we found that it's not really a threat for us?
Yeah, it's not actually a global threat for now because the outbreak was they were able to contain the outbreak globally. I was looking at the live dashboard for WHO this morning. We have 10 cases. 8 were confirmed, and we have 3 deaths, which is like 38%. I think by now, the NCDC should have given some travel advisory to countries around the western region of the continent.
Do you think it's because they don't want to create panic?
No, it's not all about creating panic. It's about speaking to global health security. Yeah, the world is so small now that people travel a lot. So let me give you an instance. About 2 British nationals are being treated now in South Africa. Some are treated in Switzerland, some are treated in the Netherlands. And we have a lot of Nigerians that travel around these countries, you know. So in terms of getting in contact with people that might have been infected with these viruses there. So we need to activate our surveillance framework. It should be active on our borders.
Yeah, well, I'm sure I will have further questions for you. Let me take it to him.
Well, thank you, Mawkwe. There's something that you cited earlier, and I think that's a good place for us to go, and that is the caregivers. In the wake of the coronavirus, we know that we still celebrate the casualties, including medical doctors. But here now, we know that usually it's the nurses first in the ER and everywhere else. So in terms of scenario planning and all of that, how is this different? Well, God forbid that it comes, but then we have to plan for it. What are your thoughts on the kind of preparation we should be having, particularly for caregivers, the nurses whom we are celebrating today?
Actually, it is a nursing week. I don't know whether this week is a nursing week or it is the previous nursing day. Yeah. So congratulations to all the nurses holding the health front for us, other allied medical professionals. I think that not only to the nurses, medical doctors, lab scientists that handle specimens and all what have you, across all the professional health cadre, we need to raise a high suspicious index when it comes to dealing with cases, not only limited to hantavirus, but to all infectious diseases. There is, I know you understand the concept of infection prevention control because I've seen you a lot of times on this channel engage medical expert on that. We need to also observe those protocols, raising high suspicious index when we are dealing with people generally. That will help to curtail issues of what is referred to as nosocomial infection acquired within hospital environment, because the dynamics is that as a healthcare worker, if you are not being careful or you don't observe the IPC protocol, which is the infection prevention control protocol, you might pick most of these infectious agents back to the community, and then the transmission cycle continues. So I think we need to raise high suspicious index in times of dealing with people that have one form of ailment or the other. And then we also need to also observe the infection prevention control protocol. There is also need for us to activate the public health advocacy framework, which is often referred to as risk communication. I expect that as I begin to query my Bolt app to see to how I can be able to recall a driver to pick me from China's television, I should be able to see a public health advisory on have you washed your hand today? Hantavirus is real, a Lassa fever virus is real. Or I want to open an app, a bank app, to send money maybe to Malpay, and then I should be able to see some public health advisory, or to IO. So I think that we need to, all hands needs to be on deck. We need to activate the public health advocacy framework. It should not be seasonal. It should not be when we have an outbreak. It should be a continuous thing. And I think the role of stakeholders into this is quite key. I've not seen a lot from the National Orientation Agency in terms of public health advocacy, even during COVID. In this station, I've mentioned that. So we need a lot to do around that. And so that's my take on this.
Well, that's given and well understood. But I also recall, and you are aware as well, that there were so many activities from public sector, private sector practitioners in the wake of the COVID-19 pandemic that we had to go through as a nation. All kinds of infrastructure was set up. We remember, I think it was the health minister at the time was saying that he didn't know that our health infrastructure deficit was so high, so significant at the time. One wonders whether those numbers have improved, particularly when it comes to dealing with emergencies. There are those who have said, specialists like yourself, Prof, that have said the next pandemic may not be as far back as 100 years before we experience it. Now, should that be, God forbid, but in the event of such a thing, what, in your opinion, is our emergency response infrastructure like right now, especially at the level of the states? I hear you about the issues of advocacy, emergency awareness and all of that, but how about the infrastructure that are going to be used, and even what you guys call the consumables that the nurses and other health practitioners are going to need, God forbid such a thing would happen?
We have gone back before COVID, and let me speak from an informed position that we still have a very fractured healthcare system, and our infrastructural deficit has gone very, very low. So let me give you an instance. I have 3 friends that set up a COVID lab for international travels. They made their money after we globally, there was no COVID again. They sold their laboratory equipment and closed their labs, and that's the end of it. So we never had plans for post-COVID. Even after COVID, we never had even a post-COVID summit, national post-COVID summit, to look at our success story, to look at where we thrived well, to look at where there are gaps, to look at how we can close the gaps. We never had it. Even when we are counting the number of deaths in terms of Lassa fever, we never had a national Lassa fever summit to actually discuss that. So the infrastructural deficit is quite low. As I speak with you now, we tend to see issues of outbreak response at subnational and local level seems to look more like a national thing. People still wait for NCDC to send a response team. People still wait for NCDC to send consumables. People still wait for NCDC to come to their states to pick up specimen for laboratory analysis. It's quite sad. So there is a huge gap. And let me also postulate here to say that in my own view, which is subject to ignorance, but there is need for us to decentralize NCDC. The coordination is quite at the national level. We need to take coordination down to subnational and to local level. This is how we're able to respond to HIV and AIDS. We have the NACA, which is at the national level. We have the SACA, which is at the state level, and we have the LACA, which is at the local government level. So what stops every state to set up their own Center for Disease Control? I expect me that I come from Nasarawa State. I expect Nasarawa State Center for Disease Control. I expect Lagos Center for Disease Control. I expect Zamfara Center for Disease Control. So that the coordination, the ownership of the coordination will be at state level and then down to the local level. I expect also every state to have a public health lab.
We don't have that now?
We don't. We don't.
It's interesting how you say we don't.
We don't. We don't. Like my state, we don't have a public health lab. Jos Plateau State, we don't have a public health lab. We don't have a public health lab in Benue. Samples have been transported to the Gadua Reference Lab for NCDC. Time has come for us to have ownership.
That is worrying.
Of all this coordination.
It is worrying indeed, because as you said, we did experience COVID, and we saw the lapses in the aftermath of COVID. It's interesting you talked about accountability. For those who are wondering where they will start from if they wanted to, I do know that Dr. Chikwe Ihekwazu, who was the Director General of NCDC at the time, wrote a book after his time in office, talking about an imperfect storm. That's the title of the book.
Absolutely.
An imperfect storm, for those who are interested to, to know just what it was like in that season. But it's really, really sad and worrying it does appear that we haven't really learned any lessons as a country.
Absolutely. We never learned, because during COVID, we brought private sector. It was private sector driven. Where are the private sector now? We refuse to also repurpose those platforms that they set up. Come to think of it, that an individual invests so much in setting up a molecular lab, and after COVID, there was nothing for him to test. We would have come up with a national post-COVID plan where those labs would have been repurposed. Okay, this lab, can you handle cholera? Can you handle Lassa? Like that.
Circling back to Hunter, you've already told us that we should be aware. We know it has no cure as of now.
It has no cure.
It can only be managed.
Yes.
But you are optimistic that it will not get here?
It will not get here by the grace of God if we activate our surveillance system framework.
I think a lot of people want to end on a note of optimism, and that includes me. So I have to thank you very much for coming on Sunrise Daily this morning. We thank you for coming. Professor Ishaku Akiela is a professor of infectious diseases epidemiology and is also the director of Global Health and Infectious Diseases Control Institute based in Kefi, Nasarawa State. Thank you once more.
Thank you, Maupe, for having me. Good morning, Nigerians.
Well, that's where we draw the curtains on today's program. Thank you so much for watching. I'm Maupe Ogun-Yusuf.
And I'm Ayo Makine. On the hour is Business Morning. Have a wonderful rest of your day.